Everybody joins in a couple of minutes. Just wanted to double check and also make sure that we know each other. Tracy, our independent consultant, who is the author of this guide. Keith Minas, the senior technical advisor, who will talk also about the Global Fund overview and the CLM and how it fits into the new strategy and the new model framework. And then we'll have Nalikanta or Kanta from India, from Manipur, who will talk about his experience in implementing CLM in that region. And then we'll have discussion panel, and we'll also hopefully, also hear from Eurasian Harm Reduction Network, Igor Gordon and Vitaly Rabinchuk from Puls Communitar from Moldova, to talk about a little bit more about their approaches. And we'll have also, of course, a Q&A and a discussion that will be open for everyone to ask questions. We actually have an expectation that there will be a lot of people joining. We had almost 180 people who registered, so looking very much forward to seeing as much as possible. So thanks so much, Emily, our communication assistant, who did a great job in making sure that we have posted it everywhere. Thanks, Emily. Great. So we'll just wait a couple of minutes. I will be projecting the slides. If you have any questions, just feel free to send me a message, a PM on Zoom. I'll try to read and respond. But I'm really looking forward to all of you, starting very soon. Okay, Annie, perfect. Right. I will start, admitting people. So Kim, if you can, Chantal, if you can also help to admit people, I think it would be great. So we'll, be able to start on time. Hello? Hello, everyone.
Good morning, afternoon. How are you, Kim?
Hi.
Hi, Kagetko.
Nice to see you guys.
Nice to see you too.
It's been a while. It's been a while, like forever. Since I saw you in Nairobi. The last time I saw you in Nairobi.
All right. So let's start. I will then ask my colleague also to help me with admitting people in the waiting room that will join. But please kindly keep your microphones off so we can launch that. Welcome, everyone. My name is Gaia. I work with the International Network of People Who Use Drugs as a program manager. And today we are launching our long-awaited guide on community-led monitoring. So let me just share my first slides with you. I hope everyone can see it. So, so let me just quickly walk you through the agenda of the meeting. So we'll start with Tracy Swan, our consultant and the author of the CLM guide, who will give us an overview of the guide and how it works. We'll proceed with then Keith Minas from the Community Rights and Gender Department to talk about the role of CLM and its importance in the global fund programming. Our speaker from India, Nalikanta Rajkumar, will talk about his experience and lessons learned of implementing CLM model in Manipur in India, and we'll have a significant amount of time also dedicated to discussion, because we really want to make sure that we hear from you, your peers, and everyone who had or had not had experience in CLM, to see how we can collectively work together to make sure that CLM works in the best interests of our community. And just a few ground rules to make sure your microphones are muted during the presentations. And we would like to record this meeting. If you have no objections, then please accept, or let us know if you don't. You can use the chat box to post any questions in the chat during the presentations that we will also take into account for the discussion. And when we start the discussion, so make sure to raise your hand. So then we will let you in and let you ask the any questions or comments. And in the end, we, as always, as per our tradition, we always take group photos of the attendees. So if you don't mind, please turn on your cameras then, or keep it off if you mind. We'll have interpretation today into languages, Spanish and Russian. You should see that in your meeting controls down below. So you will see the interpretation button. So you can click on the language that you would like to hear. And if you want just to hear the interpreted language only, you should click the mute original audio. Please don't mute it during the Q&A, because the translation, oh, sorry, actually, no, this is, no, the translation will still keep in the main, in the translation channel. So this is actually not right. So yes, our guide is published. So it's officially now published on the website, and we will make sure to send you the link alongside with all the resources and all the slides from the speakers. So just in a few days I will share everything with you, and you will be able then to have a proper look at the guide. Without further waiting, I will invite Tracy to introduce us to the CLM guide. So Tracy, welcome. I will share your slides now.
Hello, everybody. Thanks for sharing your time with us today. I'm going to talk a little bit about the guide. For those of you who don't know me, my name is Tracy Swan. I'm an independent consultant who has spent more years than I'd like to count working on HIV, harm reduction, hepatitis C, COVID, TB, human rights, access to medicines, clinical trial design, etc. Next slide, please. So for those of you who aren't familiar with community-led monitoring, or CLM, it's really a formal mechanism for what communities of people who use drugs have been already doing for decades. You know, collecting and sharing information about human rights violations and their access to and quality of the harm reduction services and programs. And the information from CLM is used to advocate with key stakeholders and duty bearers to improve and expand services, and to push governments to adopt anti-stigma, anti-discrimination, and decriminalisation policies that uphold dignity and human rights. Next slide, please. So CLM really came from a collective recognition that just because services exist, it doesn't necessarily mean they're optimal, and that often people who are members of key populations face specific barriers, stigma, discrimination, and that it's really, really essential to uphold their human rights and make sure they have access to prevention, testing, care, and treatment services for HIV. And I think the fundamental principle of CLM is it relies on the leadership and expertise, in this case, of people who use drugs, right? It is community-led for a reason. I think really it's about communities sitting down and saying, what are our advocacy issues? What's missing? What are we not getting? And then working on indicators, which are a set of specific questions to measure that. And then meeting with people who are accountable, duty bearers, other stakeholders to address the problem, and conducting additional advocacy campaigns. But CLM does involve working with national health authorities and these other stakeholders to find solutions. So there is accountability built into the model. Thank you. Next slide, please. So I think this is a really great quote. Some of you may know Angela McBride, the executive director of INPUD. It's actioning the evidence you collect. It's not collecting information for its own sake, because we all know it just sits in a folder and it doesn't change anything. This is really advocacy focused. Thank you. Next slide, please. So the CLM guide was developed to introduce CLM to people who use drugs, the organization and networks, and to provide resources that support implementation of and funding for CLM. So in some ways, CLM is really straightforward. Communities identify the problem and an organization then can take leadership. But there are some core principles. Different funders have different definitions, but there's quite a bit of overlap. And in this case, there's a really specific context for people who use drugs, which I will talk about a little later. It defines a framework for CLM. And I think the bedrock of CLM, global recommendations and targets, because if things are not meeting a standard, it's really important to have a global standard to hold them against, to say to the government, look, WHO recommends this, or to look at your own national guidelines and see if they're aligned with WHO guidelines. And if they're not, to really start from there. And then there's just a global CLM agenda and how CLM and human rights are so closely intertwined. And the cycle of CLM, there's examples of some projects and programs that have implemented CLM for and with people who use drugs. And then there's some more technical aspects of CLM that we know are important, but the guide is really an introduction. And all the resources for people who want to go deeper are listed in the back. But it's supposed to be more friendly to the reader, so they're not immediately overwhelmed with a lot of the technical aspects and sort of go in at their own pace. Thank you. Next slide. So, and the guide really outlines the fundamental principle of CLM, that it's community-led and owned, and it should build power and capacity among communities, and uses data to support advocacy, reinforce accountability, and improve health care and policies, in alignment with nothing about us without us. And I was thinking about nothing about us without us and all the services that have been developed over the years for people who use drugs, and it's really more like nothing for us without us. Right? Like that's where the services came from. There are some services now that aren't even funded yet that are really cutting edge and responsive to what the community needs. And CLM can encompass this. And the guide will cover or provide resources for developing funding requests and implementing CLM, such as good practices, the technical aspects, confidentiality and data safeguarding, developing specific questions for your CLM. And again, it has examples of CLM projects conducted by people who use drugs. Next slide, please. And there's a whole advocacy cycle for CLM to state the problem and the goal, like what's your advocacy target? Say your local NSP isn't providing enough syringes or isn't open during hours when people need to access it, etc. So you begin with a problem statement and you identify your audiences. Who are the people that have the power to influence this? You identify your allies and your opponents. Who can support your advocacy? Who and how strong are your opponents? Determine your tactics. What are you going to do to achieve your objective? And what data do you need to highlight that will encourage duty bearers to take action? What's your strategy? And develop an action plan. What's the best time to use your tactics? And what's the best way to ensure that your tactics have the maximum impact? So I feel like strategy is baked into this from the very first steps. What do you want to get out of this process? What needs to change? And this advocacy cycle is just a very nice way of and clear way of looking at it across the CLM framework. Next slide, please. So I've been involved with capacity building on CLM projects for HIV and TB and Hep C also, specifically on treatment education and strategy for 6 years. And it's so important to hear community needs, priorities, and experiences. And as an educator, you know, the average person always knows that their rights are being violated or that they're badly treated, but they might not know what the WHO and national guidelines and policies recommend. And this is really important for developing indicators and for advocacy. You know, if the target for syringes is 200 per person per year, which is not nearly enough, but, you know, what if you're getting like 20 per person per year? You have something to say, this is a normative guidance, and this is what we're working towards, that can be quite effective with policymakers. And the average person may not be so aware of those. And I think, you know, explaining what you want to monitor within the framework of this is the minimum standard for what's considered globally acceptable is very important. And the other part I think is really important is developing indicators, which is a fancy term for questions about services that cover both the amounts, like how many needles, and the quality, like how are you treated during your visit to the program. And these indicators are used for your CLM and to identify advocacy areas, targets, strategies, and campaigns. And I think I've many times been offered the opportunity to ask questions about what's not going right. And I think picking your indicators is really important because you don't want to monitor too many things. You basically want to point your arrow right at your target and have a question that gets right at that target when you're doing it. And, you know, sometimes I found people don't have the resources or the time to really invest in people who are collecting data, right? So I've heard stories like, you know, we're monitoring HIV treatment stockouts, so we go in and count the pills, but people don't get the information about which pills are you counting? Why is it important that these pills are here? What happens if they're not? And to me, that's not really community-based work. And drawing everyone in, having them work from the same set of information is extremely important. Next slide, please. Or did we skip the one on CLM that's really through? Yes, here it is. I think it's really super important to look at CLM through the lens of people who use drugs, like considering power imbalances. Who should monitor harm reduction programs and how should they do it? Where should they do it? You know, some services are punitive and no one wants to face a reprisal for collecting information, say, at the place where they're a program beneficiary. On the other hand, communities are justly not necessarily immediately embracing of strangers that come in. And I think it's really worthwhile to spend some time sitting with communities and saying, how do you want to do this? There are places that have really been hostile environments for people who use drugs that are not community-based sites. So the discussion, I think, really needs to begin. What is the outcome you would like from the CLM? And how do you want to go about it? I'm really looking forward to hearing the other presentations, to hear about how people went about it. And the guide doesn't really instruct, it raises questions to help people figure that out themselves, not to tell them how to do it. While there is a structure and a method to CLM, there's definitely room within that for how you do it. And that's it for me. I'm really looking forward to the rest of the discussion, and I hope the guide is helpful to all of you. And thank you, everybody.
Thanks so much, Tracy. This is a great introduction, and thank you so much. I think it's a wonderful work that was put together, and we have, indeed consulted a wide range of partners and community leaders and peers, and I think it's really a great, solid guide. And I will now pass the floor to Keith. Keith Mina is the Senior Technical Advisor for Community Rights and Gender Department, who will talk a little bit more about how CLM is framed within the Global Fund, within the strategy, and with the Grant Cycle 7, as it's, of course, a very important tool. And yeah, so Keith, please welcome. I'll share your slides right away.
Thank you. Thank you so much, Gaia, and good afternoon, everybody. It's really great to be here. And like Gaia said in the beginning, this has been a long piece of work in the making. I remember us having conversations right at the beginning of what this should say and how this should look like. So incredibly grateful for this piece of work to be where it is today and for you to launch it. While Gaia's pulling up my slides, just to thank Tracy for that overview. I think, two things really stand out to me as the focal point for community-led monitoring here in the Global Fund that Tracy spoke to. One being the importance of being able to report against things you know about. If you don't know, you don't know. And so it's one thing to say that these are my rights and these are the things that I'm entitled to, but it's another if you don't know what treaties and guidelines and policies and SOPs say about those rights and what are the opportunities if those rights are infringed for you to seek redress. And then the second thing, and I think I've spoken to INPUD about this a bit, is also sort of the attitudes towards drug users. If you think about community-led and communities of drug users being in the lead and driving seat of CLM implementation, of course, hostility, stigma, discrimination, stereotypes influence ability to do advocacy. And so I think as we go into and as you operationalize some of this guide, it's important to also make sure that you understand the limitations in those spaces and in those places and who holds those seats, and how you provide the priorities back to decision makers about this. And I'm eager to learn about your experiences. So my slides today is really just to share with you a little bit about why CLM is so incredibly important for the Global Fund, and align it to the guide launch, but also to share with you some of the thinking of how we've adopted and adapted as the Global Fund in the last cycle. CLM is not new, but it is new in the way we are doing it. And it's certainly new for an entity like the Global Fund to invest very structurally in this type of intervention. So next slide, please. So our new strategy, everybody has seen it. It's quite comprehensive. It places an incredible focus on the people and communities who are recipients of care, but also influencers of care, and the health system in terms of engagement. So really wanting to emphasize the mutually reinforcing contributory objectives. The slide is a bit busy, but I will tell you now how it is operationalized. In terms of the contributory objectives, you'll see 3 blocks there in the middle. People-centered integrated systems for health. You can't talk about people-centeredness if you don't give people the opportunity to provide feedback on the health services that they receive. Engagement and leadership of most affected communities and leaving no one behind is important in spaces and places and around the tables that I was talking about earlier. And then ensuring health, equity, gender equality, and human rights are observed are all important for community-led monitoring. And they are all contributing in some way to one of these contributory objectives. Next slide, please. Previous slide. Yeah, so what does that look like? So I was just going to touch on one of them and to show you how CLM is being called out, how it's been mentioned in the strategy and prioritized, how the definition has been adopted, similar to what Tracy was talking about, with the exception of also making emphasis on financial and programmatic decision-making at all levels of the health system, not only in terms of health quality, accessibility, availability from the recipient of care perspective, or even the whole human resources for health, but really also in how allocations and resources are allocated for particular quality improvement and the reduction of human rights and gender-related barriers to services. Next slide, please. So how do we take a strategy with beautiful words and how do we operationalize that into grants, which is the crux of this conversation, right? Like, how do you access global fund financing in response to some of the disease components and priorities, but also how it links to some of the programmatic essentials. And so I wanted to show you just very quickly the 4 information notes, which, as you know, is like the Global Fund's version of a guideline of how global fund investments can be leveraged within each of these disease areas, but also in resilient and sustainable systems for health. Each of them, and you will see when INPUD shares the slides in the annex, I have pulled out the content in each of the information notes to link you to, but I will quickly show you the HIV one. So if you can go to the next slide, I would urge you to go back to all of them and depending on the disease priority to look into them, because this is the level of detail that they contain. There are programmatic essentials in each of the diseases, including in RSSH, and you would see that CLM is mentioned under each and every one of them, which is incredible and really fantastic. And similarly, it applies to tuberculosis and malaria. Of course, all at very different places and spaces of how they have evolved and matured. But for HIV prevention, this is a new focus, and I think also really important for the audience of this call. Think about integration of human rights as well as quality of HIV prevention services and outcomes through community-led monitoring. Typically, we've looked at community-led monitoring from an observatory perspective and very focused sort of on care and treatment, as well as at the level of the facility. As we are thinking about differentiation, decanting services outside of facilities, making them more available at the level of the community, the approaches, the frequency of monitoring, the type of data collectors, the type of data you collect are all important things and influencing factors as you design your CLM mechanism. It's also important to note that community-led monitoring over the years has not been as much, but it is becoming a key strategic information point for us to assess at the level of the country additional information on the AAAQ of these services, particularly here to HIV and SRH and other integrated service delivery, but importantly to assess against the strategic information. So if there is an IBBS, if there are programmatic reviews, if there is a midterm evaluation of the NSP, it's important to bring some of these findings and this qualitative information into some of those conversations. Next, please. So we've spoken about sort of the guidance and what you are meant to do. We've spoken about how that guidance is operationalizing the ambition in the strategy. This essentially is the programmatic or modular framework, as we call it in the Global Fund. It's an extremely lengthy document, but at the end of the day, it provides you with all the sort of eligible activities that are to be funded through the Global Fund. And I really wanted to show you this because in the last cycle, we were able to make some major revisions on the modular framework as it relates to community-led monitoring. So next slide, please. So you'd see in previous times, we spoke about community-based monitoring. In alignment and in respect in adopting the PCB definitions, the UNAIDS PCB definitions on community-led, we've updated some of the language to reflect that guidance and the drive for community-led monitoring and community-led accountability mechanisms to be supported through Global Fund resources. You would see on the right-hand side of the slide what's highlighted in red and bolded on new. So we are also now supporting through Global Fund investment the development of national community-led monitoring frameworks and strategies. Important as CLM evolves and are scaled up by different communities for different diseases in different locations, using different types of indicators and tools, paper-based versus digital. It's important to start coordinating better because you can all generate information and indicators, but it's about how do you bring that together and how do you support one consolidated advocacy ask as it relates to a particular disease priority or community. Of course, implementation of CLM now is eligible. It's always been eligible, but it is the full cycle of CLM because if you remember, GC6 started without normative guidance. And in the year one, I think it was 2020 or 2021, we developed the UNAIDS CLM guidance, the international one. Support for piloting of CLM mechanisms are eligible. Technologies for data management and storage are eligible. Technical support and training, which is probably the most important one as I get to the end of my slides, for you to build in technical support and assistance needs into your grant budgets. And also for participation and presentation of the CLM data in various governance and oversight mechanisms. Next slide, please. So what are some of the lessons that we are reflecting on as we go in, and maybe something for you to consider as you go into designing and implementing your own CLM for PEPFAR or CLM in harm reduction or CLM for KP programs or mechanisms? Apologies. We're seeing a wide range of CLM budgets from really tiny amounts to really big amounts, which are all very exciting, but also daunting. So make sure that your CLM mechanisms are costed well. There are several resources now. If you go on ITPC, clmhub.org /ITPC, I think, and I'm happy to share it in chat. There's a resource hub, including costing guidance and some information on how to think about developing a budget for a CLM mechanisms. It's often, what we are seeing a lot in grants is that CLM is often think about as this like one way of doing something in a very particular instance and not necessarily tied back to the bigger piece of engagement work or, how do we assess quality of programming or how do we provide feedback on when people say there are issues in terms of program or service access. Hence also the prioritization of supporting that CLM frameworks. We are seeing a proliferation of approaches and models just out of grant making in several countries, in Ghana, Nigeria, and others. And it's really exciting to see that each community or each disease or each network, TB network, PLHIV network, etc., are wanting to do their own independent CLM approaches, which is fantastic. But at the end of the day, my question is always about how do you bring all of this together? Each of you sitting on bits of data is obviously not as strong as all of you sitting on collective data and having good evidence for you to drive advocacy. There still seems to be quite a big lack of a CLM understanding, I think mostly from governments, but also quite often from the community partners themselves. We don't have platforms to share experiences. So within the PEPFAR community, it would be great to continue this type of sharing of experiences in communities of practice. CLM does take time to set up, and oftentimes we don't take that into consideration. So we go from 0 to 100 in year one, and then we fail. I think it's important to think about a phased approach as you think about this. And setting this up, this is new, noting some of the challenges and limitations I spoke about earlier in terms of resistance and hostility, but also in terms of making sure people actually understand the health and legal rights that they're entitled to for you to do effective CLM. CLM for HIV is still most advanced. TB is growing in a really interesting way, and models for malaria at this point, almost non-existent, but actually they are existent, and they just called community-based monitoring and are implemented through community health workers, which are also great and really exciting. And we are trying to grapple with how do we marry community-led with community-based. Next slide, please. All right, so very quickly on resources and tools and things that are available to you. This is the guide I was talking about. If you were to think about CLM for PWID or CLM for KPs or CLM in general, to be included in your Global Fund funding request, this is the guide. We really made it as simple and straightforward as it possibly can be. It literally gives you words for the funding request template. It gives you the budget lines and the categories for the templates and how to go and process that with a CCM. It's an incredibly great guide. It's available in Russian, Spanish, French, and English. Next slide, please. This is the hub. These resources you'll see here are all on the hub that I was talking about earlier. We were going to make another hub, but ITPC beat us to it. So good for them that there's now one central place for all these resources. They've all just kind of mushroomed and they are all over the place. So it'd be great for you to play around with them, see what's important, see what's helpful, see what you can do. We've broken, if you look at the bottom left, you'll see that there's different specific thematic areas, data management tools, which is one part of the cycle, data analysis methods, which helps you with the advocacy, how to think about CLM in a pandemic, how do you move from insights to making that data and evidence rigorous and provide you as the evidence for advocacy. Next slide, please. These are relevant to COVID specifically, so we've also supported that over the year, and we'll continue to do that. Obviously, the shift is no longer COVID. It is now pandemic preparedness and responses, if you've heard new Global Fund language in this area. So it's all about prevention and being prepared, infection prevention and control and surveillance. We are all thinking this through, and we'll come back to you through the regional and global networks for a consultation on what this looks like going forward. Next slide, please. So these are the 3 TA provider consortiums that we've been partnering with over the last 3 years. And I must admit that I'm not the bearer of good news, but at the end of the day, the community-led monitoring strategic initiative is coming to an end in December. So as you might have hoped or assumed, that there's central technical assistance available for CLM implementation through Global Fund grants. I'm here to tell you that there are none available after December 31st of this year. The SI is closing out for various reasons. As you know, the replenishment outcome has not been as successful and a lot of trade-offs had to be made. However, I would urge you to, again, make sure that technical support for CLM is built into grants. It's as simple as adding a budget line to say this is TA for CLM for PWID scale up. This is TA to support CLM advocacy across KB communities. What we can do, my team can do here in the Global Fund, is to link you up with the right experts based on what you need and where you are. I think that's one good way of sort of making sure the TA providers are appropriate and relevant to your needs, but also speak your language and also have experience from your region. So these are them. You could reach out to them independently. You could reach out to through Gaia or reach out to me, and I will link you up with at least 2 senior program officers in my team that looks after CLM with me. Next slide, please. These are a bunch of resources that I, again, urge you to click on, take a look at. It's really, really helpful just to give you a general flavor of where the world is at with CLM. There's a lot of case studies in there. There's some good examples. There's some incredible lessons learned in there that might be helpful to you as well. So, so please consider this, and I hope you found this helpful, but really exciting to see this guide being launched, and excited to see how this piece of work continues in Grant Cycle 7. So please reach out if you have any additional questions. Thank you so much, and back to you, Gaia.
Right, thanks so much. Thanks, Keith. This is a great presentation, and I think it's really good to hear also like your honesty about what's available, what's not available, and also like for continuous support and availability of technical assistance of you and your team at the Global Fund. So really great. I will now pass the floor to our final speaker from India, from the state of Manipur, Nalikanta or Kanta. So Kanta will speak about his experience and his organization experience on implementing CLM and what worked, what didn't work, what challenges you faced. So please welcome Kanta. Please, we'll share your slides right now.
Thank you so much, Gaia. I hope all the participants that we have today must be from the different time zone. So good morning, good afternoon, and good evening to everyone. Slide.
Yes, sorry, my computer is a little bit slow today, but yes, here you go.
Okay. Yes. So first of all, I would really like to express my gratitude to INPUD for having me here. I feel so good and excited to present this CLM model because this is one of the initiatives that which is really helping us to identify the bottleneck in terms of, assessing the service related with HIV, Hep C, and Hep B. At the same time, also providing us the opportunity for treatment, education among people who inject drug and addressing human rights violation faced by PWIT and PLHIV community. Next slide, please. So let me start by giving you a brief background about our organization. CON stands for Community Network for Empowerment, which is a drug users-led network of 11 community-based organizations of people who use drugs based in Manipur, India, and it was established in 2011. As per the studies conducted by Ministry of Social Justice and Empowerment, Government of India, we have they estimated drug users population to be around 34,344. So to give you a background, a little bit on the prevalence of the infections, it is very high among people who inject drugs. We have around 65 percentage hepatitis C prevalence. Hepatitis B prevalence is around 10.8%, whereas hepatitis B and C prevalence is approximately 4.8%. In terms of the activity that we are taking out, we are working on a range of activity which include promotion and protection of health and human rights of people who use drugs, improving access to HIV, hepatitis B, C, screening, vaccination, diagnosis, and treatment, and to stop human rights violation among people who inject drugs at the drug treatment centers. Next slide, please. So to give you a background about the CLM work that we are implementing now, we are monitoring the treatment access barrier across 3 diseases, HIV, hepatitis B, and hepatitis C under the framework of acceptability, accessibility, availability, affordability, and service quality in 6 health facilities, including 2 large referral hospitals and 4 district hospitals. And the indicator on the 3 diseases were developed based on national and global guidelines. We have developed both the qualitative and quantitative indicator. Monitoring and collection of data is led and done by the community from the people who use the community.
And the global fund
And qualitative indicator data are collected on a daily basis.
Kanta, we can't hear you.
Oh.
Ah, yes, we can hear you again. Great.
Okay then. I will start from the beginning this slide. See, what we are actually doing is we are monitoring the treatment access barrier across 3 diseases, HIV, hepatitis C, and hepatitis B under the framework AAQ in 6 health facilities, including 2 large referral hospitals and 4 district hospitals. And the indicator on the 3 diseases were developed based on national and global guidelines, and we have developed both the qualitative and quantitative indicator collection. Monitoring and data collection is led and done by the community from the people who use drug community. Qualitative indicator data are collected on daily basis and enter simultaneously into the software, while the quantitative data are collected and enter on a quarterly basis. You can of all the data that we are collecting, you can find a digitally projected result through a dashboard. So Treat Asia Bangkok, at its Anderson Office of Public Policy in Washington, DC, is the one who is providing us technical support to create this dashboard. Next slide, please. Okay, coming more into details about the indicator and data projection. The data dashboard has different area divided into the framework of AA, AAQ. Each area has different section, and each section has different indicator. Of all the indicator that is showing here, some big picture indicator are pre-selected and projected as chart. This chart provide a curated view of the most important data for this section. Next slide, please. Yeah, and this slide talk about the individual indicator. Based upon the tools that we have developed, we have various individual indicators. So the user can select this individual indicator and understand the responses. Each area has a section with different individual indicator. You can see the result of any of the indicator pre-selected and project in the form of pie chart and bar chart. Next slide, please. Based upon the analysis of the data that we collected, we have also tried to highlight some advocacy gap in the website. And data collection process also provide us a big opportunity for treatment education among the community and addressing human rights violation, stigma, or discrimination faced by PIVIT or PLHIV community. After analyzing the data we collected, we also generate facility-based report for policy advocacy purpose. And the real-time information available in the dashboard assists us in the process of addressing the important issue immediately. Next slide. Okay, I will take more time here. Let me just cite you some example of advocacy again. That is the result from our CLM work. The first result is near home assessing care and treatment. It is all about a patient whom we identified during data collection process with advanced cirrhosis. He was having extreme difficulty while initiating and continuing his HCV treatment at the tertiary hospital. So what we did was we, after speaking and meeting with the patient treatment center, he was transferred to a health facility at the district where he resides, making it much easier for him to attend his clinic appointment and receive the medicine. Second result is about successfully completing hepatitis C treatment cascade. During April to September 2023, we met number of people who inject drug who had completed hepatitis C treatment but had not undergone their SBR test to confirm whether they are cured or not. So what we have done was those 20 people who inject drug were successfully referred for completing their SBR test. This service user and the issue they are facing were identified during the data collection process. And the third result is about denial of hepatitis C treatment. This was the incident that we identified during data collection process in July 2023. So due to stock out of sofosbuvir and belpatasvir combination DAA drug, his hepatitis C treatment initiation was deferred. So we immediately convened a meeting with the State Nodal Officer, National Viral Hepatitis Control Program for alternative arrangement of his medicine. So following our intervention, she managed to provide the medicine to the patient by reallocating the required DAA drugs from other districts. So the patient is now already initiated treatment with sofosbuvir, velpatasvir, and ribavirin for 12 weeks. The fourth result, we talked about the initiation of HIV treatment after a gap of 5 years. During the data collection process in August 2023, we identified one respondent who is a spouse of people who inject drugs, who had stopped taking ARV drug since February 2018 due to unaffordability of the testing cost for routine monitoring, as the staff in the ART center asked her to do his routine, his investigation test at the private laboratory. So the action that we took was we take the patient to the ART center. Our staff managed to get done her clinical investigation at the government health facility, and she was linked to ART center for the initiation of HIV treatment, and she has now already started his HIV treatment. So before presenting you the next result of our CLM, drawing your kind attention, I would like to note that the indicator of the CLM that we are implementing now was actually developed to monitor the treatment access barrier of HIV, hepatitis C, and hepatitis B. But the very interesting part is during the data collection process, we come across many instances of right violation at the family level. Many of the spouses of drug users living with HIV are facing horrible experience of violating their rights, though they do not have any idea about seeking legal support. So one of the results that I will talk about on human rights is about a teenager living with HIV who is a daughter of people who inject drugs. While conducting a CLM interview, we met a teenager who had been abandoned by her father. Both mother and daughter had been self-reliant, but her mother became unemployed and unable to support her needs. She sought financial assistance from the teenager father to support her education, but he had refused to provide child support. So what we did was we filed a case against the father at the family court through the legal aid clinic court, and now the case is going on. The next result on human rights is that in March 2023, the CLM team member met a woman living with HIV in a serodiscordant relationship. After living together for about 4 years, her husband started abusing her mentally and physically due to her HIV positive status. She was disowned by her husband and forced out of her home, but was not granted a legal divorce nor offer any financial support. So through the legal aid clinic established under Manipur State Legal Service Authority, a case was filed against her husband at the family court. The woman has been provided free legal counsel by the Manipur State Legal Service Authority, and now the case is going on. Unfortunately, delay in scheduling a court hearing due to the current political unrest in the state. So to conclude, here are some of the challenges that I would like to highlight to the audience today. The collection of quantitative data from the government is a big issue. Is one of the biggest challenges we have ever experienced is to collect quantitative data from the government. It will take more than a month to provide us the quantitative data, whether it is for HIV or viral hepatitis C or viral hepatitis B. They don't have data for those people who are below 80 years. Data are not segregated as per our requirement. There is no male and female breakup. So this is one of the biggest challenges that we have ever faced. And in terms of collecting the data from the respondent, and for your kind information, all the respondents whom we are collecting data are people who inject drug and PLHIV, and PLHIV are those who are the spouses of people who inject drug. So the most challenge due to I think many of you must be aware of the prevailing situation in my state, Manipur. Since May 3rd, there is an ethnic clash going on between two community, due to which many people are, facing a lot of problem while trying to access the services. So political unrest is really hampering us while collecting the data. And the another challenges that I would like to highlight to the audience is all the national program, whether it is for HIV or hepatitis C. People are expecting, they are expecting people to come at centralized setting. Services are yet to be decentralized, due to which during this political unrest, people are not able to visit the health facility to collect their medicine. So we are the one facilitated, so collecting the medicine
Using the
on their behalf and delivering to them. And do I still have time? Or else I can conclude
Just a few minutes, yeah, to wrap up, so we have
Okay,
time.
then.
Yeah.
I will conclude here. I will be happy to answer if you have any question. Thank you.
Thank you so much, Kanta. This was great presentation, and we're just right on time to move on to a very important part of this webinar and this discussion. So maybe I'll just ask one quick question to Kanta, to you, about your 3 key advocacy tips to the community, to everyone who gathered together from your experience. You have spoken so much and so interestingly about the challenges and really fantastic advocacy gains. What would be your 3 key advice to us?
Okay, my first key advice to all the audience is trust the people who inject drug community. Whatever that we are doing now is by the people who inject drug and PLHIV community. We can do quality work as much as any other people, be it researcher, science, or the doctor. Everybody has their own set of skills. We are good in what we do. So trust your own community to do quality work. This is first key message that I would like to convey to the audience today. And the third message would be, don't collect data that you will not use. The shorter the indicator, the better we can use it for advocacy purpose. This is the second message, key message that I would like to convey. And the third key message will be, always look at the big picture. By big picture, what I mean is international commitment and target. What we are doing is basically contributing to the bigger pictures. We are just doing small scale work at the grassroots level. Therefore, I would like to suggest the audience to look at the big picture while you are developing the indicator. Thank you so much.
Thank you so much, Kanta. Thanks everyone for a really great presentation. So I'm now opening the floor to the discussion, to any questions you have. I saw quite an interesting already discussion happening in the chat box, and I see Keith have already answered quite a few. And I saw that we had also in the chat people from EHRA and also from INPUD who would like to also share their experience. So I may I invite Igor Gardon, I think, yes, from EHRA, to just talk a little bit about your experience with CLM. I heard, and I think also participated in one webinar. It was really interesting. So if you could share just what you are doing from EHRA perspective, that would be great.
Yes, sure. Yeah, thank you, Gayane. Thank you, colleagues, for inviting me for this very important and interesting event, webinar. So I am Igor Gordon from the Eurasian Harm Reduction Association. We, as a regional network, supporting communities in every aspect in implementing CLM. But before I go to our association specific activities and examples, I would like to talk more about our initiative, we as a Eurasian Regional Harm Reduction Association initiated last year the idea of having joint position of regional networks and key communities on community-led monitoring. So, and this year in January, at the end of January and beginning of February, we had a meeting in Istanbul where we jointly with key communities and other civil society organizations on regional level have developed a document that presents collective efforts of almost all communities and civil society organizations in Eastern Europe and Central Asia. So, and this meeting resulted in a shared vision of CLM in the region. And it's also like, first of all, it defined a CLM as an ongoing process where the communities itself monitor and drives positive changes. And this document also underscores key principles of CLM implementation, emphasizing the community leadership and independence. I will share in the chat link to this document so you can see it. And one of the crucial aspects addressed in this document is the management of conflict of interest. And it emphasizes the importance of independence and ethical consideration in CLM initiatives. So we discussed and we had like very difficult discussions, especially the role of donors, the role of other big civil society organizations, like a global one and regional one, who provide different kind of approach to CLM. But it's very important that communities itself should decide if they accept those approaches or not. The document also highlights the critical need for sustainability of CLM process. It involves like funding, legal support, and community capacity building. And also the document offers key recommendations for community organizations, government, agencies, and donors in CLM efforts. So I would like to really share the link to the document if I can, or maybe I will do it later on. But what is important that after this consensus document, we also have developed our next steps, what we will do next, and kind of roadmap. And as an example, so one of the steps that we will have very soon, this will be the meeting of community networks with Global Fund regional team very soon, actually next week in Geneva. So the regional representatives of key communities will discuss with Global Fund specialists and team key CLM issues, what we have in the region related to the new Global Fund country proposals and how CLM will be implemented within these proposals in country. So I think it's very important step. What does it mean for the global perspective? I mean, I think it's maybe this experience can be also implemented on global level. So we cannot do it alone as a community of people who use drugs. So I think we should do it together and to combine our efforts with other communities, and also to have maybe this initiative invite other communities to find a consensus on what does it mean CLM for all of us. So, and another, but we as a network, so we have a lot of things to do with CLM. And first of all, we also have a very practical handbook where we have collected almost all methods of doing CLM in one book. It's a rather huge book with I don't know, 600 pages, but it's really practical, in fact, because it had like a very detailed description of CLM concept and the main implementation step, as well as practical ready-to-use methods to conduct CLM. I will also share a link to this document. But even more, we are also linked to this practical handbook. We have developed web tool to select CLM method. It's very easy to use this web tool. So every community, if they know what they want to monitor, they can select appropriate method of CLM according to their resources, how much money they have, how much time they have, and also how difficult method they want to use. And even more, we as a regional network, we're also supporting communities on the ground, providing sub-grants. For instance, so Vitaly Karbenchuk, I see here his hand. He wants also to say we also have provided a couple of grants to them and supporting them in conducting CLM. Maybe he will present results of this CLM. But so we have on our side examples, practical examples, how communities already implemented CLM monitoring on their country and municipal level. So you can get more closely to know what they do on national level. So this is basically what I wanted to present. And I will share right now all the links so you can see it. Thank you.
Thank you. Thanks so much, Igor. Really great work done by HRA, and very much hopeful that the meeting next week will go well, and it will be will bring a lot of useful outcomes. Well, most importantly for us and our community. I see Vitaly, yes, raised his hand. Vitaly, please come in. Пожалуйста. Then for anyone who needs translation, can you please then switch and use the Russian-English translation, because Vitaly will speak in Russian. Thank you.
Да, добрый день, коллеги. Спасибо за возможность представить наш опыт. Я представляю Евразийскую сеть людей, употребляющих наркотики. Мы выступаем за равный доступ к услугам здравоохранения и оставим наркополитику, чтобы иметь равные права. На протяжении 20 лет уже у нас существует финансирование глобального фонда, за что мы очень благодарны. Однако наличие определенных услуг не всегда обеспечивает нам наличие само по себе, не обеспечивает нам достаточный доступ и приемлемость этих услуг. И в этом контексте мы благодарны Евразийской сети, вернее, ассоциации снижения вреда, которая предоставляет нам свободный путь нашего развития в области CLM, то, что Игорь сейчас упомянул. В этом контексте, благодаря финансированию Евразийской ассоциации снижения вреда, сеть, в которой я работаю, Евразийская сеть людей, употребляющих наркотики, выработала гайд по CLM. Мы видим, что это была актуальная и своевременная работа. Почему? Потому что в последнее время до этих пор мы не находили никаких руководств по CLM. И мы были вынуждены самостоятельно разработать свое руководство, и которое сегодня мы используем. Это руководство, которое мы разработали в INPUD, оно позволяет иметь картину различных подходов для мониторинга различных направлений, в том числе связано не только с услугами общественного здравоохранения, а также правовыми и другими детерминантами, которые так или иначе затрагивают нашу жизнь. Правовые барьеры или, может быть, социальные вопросы. Там достаточно большой список инструментов и подходов, которые можно выбрать для того, чтобы они были согласованы с теми ресурсами, которые мы обладаем, или та или иная группа в нашей сети обладает. А в нашу сеть входят 13 стран региона. Так вот, для нас никогда не стоял вопрос, что надо делать по CLM. Для нас стоял вопрос, как это делать. Как это было всегда связано с определенным уровнем нашего потенциала, развития опыта и навыков. Так вот, этот гайд, он позволяет, независимо от того, на каком уровне развития находится то или иное сообщество или та или иная группа в странах, или в стране, или в городе, которая, допустим, имеет гипотезу того, что та или иная услуга недостаточно приемлема и недостаточно объемно обеспечена, или, может быть, само наличие не отвечает нашим требованиям, этот инструмент позволяет выбрать необходимый подход и для того, чтобы сохранять баланс между ресурсами и возможностями, о которых говорил Игорь Гордон. Другой момент, когда этот гайд позволяет ориентироваться на то, чтобы исключить конфликт интересов. Что я имею в виду? Когда мы говорим о CLM, то мы должны подразумевать о том, что это должно быть под нашим руководством. И не с привлечением нас на каком-то фрагменте осуществления мониторинга, а именно то, что мы выберем тему, и то, что мы будем руководить всеми процессами. Однако, когда мы начинали свое развитие по CLM, или когда наполняли этот гайд, у нас возникал всегда вопрос, а что, если ресурсов не хватает, если не хватает опыта, если не хватает знаний, если мы, допустим, вовлечем человека, допустим, с опытом или знаниями, которого нет в нашей группе сообщества, будет ли это CLM? Да, будет. По причине того, что техническое задание для такого специалиста будем составлять мы. Мы будем его знакомить в этом техническом задании с теми целями и задачами CLM. И мы будем вычитывать аналитику и интерпретировать. Оно будет все под нашим руководством. Таким образом, отсутствие специалистов, знаний, опыта ни в коем случае не ограничивает наше сообщество для того, чтобы руководить этим процессом. А другой момент, что когда мы начинали мониторинговые мероприятия, то вначале нас воспринимали, как, знаете, людей, которые выискивают виновных, для того, чтобы распределить вину между ними. Ни в коем случае. Мы выступаем партнерами, которые результаты CLM просто дополняют или указывают на те вещи, которые не были замечены и не были в фокусе зрения стейкхолдеров или, может быть, доноров. И таким образом мы выступаем равными партнерами и отстаиваем свои права. И помогаем больше или расширяем кругозор для того, чтобы увидеть полную картину глазами того сообщества, которое пользуется этими услугами. И тогда надеемся мы, что результаты этого исследования будут полезны для стейкхолдеров, для национальных координаторов программ, для доноров, для того, чтобы понимать, куда влаживать деньги, как изменять те или иные подходы, как дополнять те или иные подходы, где прилагать усилия. Так вот, приведу некоторые примеры, которые мы делали и которыми мы гордимся, хотя их много, но я приведу всего лишь один, чтобы экономить ваше время. Один из моментов CLM, который мы делали, мы хотели увидеть, насколько национальные стандарты соответствуют в нашей стране практике, существующей предоставления услуг по программам снижения вреда. Насколько они наполнены теми инструментариями, которые соответствуют реалиям наркосцены. А сегодня наркосцена изменилась. Для того, чтобы стейкхолдеры могли при формировании потребностей по инструментарию правильно закупать для нас те или иные инструменты по профилактике и в том числе по лечению. Я имею в виду сейчас заместительную терапию. Другой момент. На чем же мы будем, с чем же мы их будем сравнивать? Так вот, мы выбрали, на мой взгляд, самый удачный инструмент это инструмент, который создала международная сеть людей, употребляющих наркотики, INPUD. А он сам, этот инструмент, основан на рекомендациях ВОЗ, UNAIDS и других международных организаций, таких как ООН. И поэтому INPUD для нас был самым приемлемым ориентиром для того, чтобы сравнить наши национальные стандарты качества предоставления услуг с руководством INPUD. Следующим этапом для нас было, а насколько практика или существующая практика в наших странах по программам снижения вреда соответствует национальным стандартам. Так вот, у нас был достаточно большой список выводов, которые показывали как лучшие стороны или хорошую практику, так и негативную практику или недостающую практику, которые может в других мониторингах, да, национальных, их не было видно, они не были учтены. Измерялись какие-то индикаторы, которые показывали, насколько, чтобы отчитаться перед донорами, насколько существует наличие этих каких-то вмешательств. Однако не учитывалась приемлемость и удовлетворенность со стороны моего сообщества, которое я представляю. И у нас получилось, что в рекомендациях было более 40 рекомендаций. Это не маленькое число. Следующий момент, о которых здесь говорили предыдущие спикеры, вопрос. А каковы площадки для того, чтобы проводить адвокацию? И мы выбрали, их может быть несколько, да? Но мы выбрали две актуальные площадки. Это CCM и вторая, чем мы горды, что мы подняли на высокий уровень парламентских площадок. И сегодня наши результаты наравне с ООНовскими структурами, ООНовскими рекомендациями и отчетами, они приняты во внимание на парламенте. И парламент сегодня работает над тем, чтобы государство имело адекватный ответ на потребности людей, употребляющих наркотики. Это не маленькая работа. Я говорю сейчас о 13 странах, которые входят в Евразийскую ассоциацию людей, употребляющих наркотики, которую я представляю. Коллеги, это так вкратце. Я попытался сжать свой спич. Если будут вопросы, я готов на них ответить. Спасибо большое.
Спасибо большое, Vitaly. Thanks so much, Vitaly. I think it was really great to hear from your perspective and yeah, a local experience, national experience. I think it's very insightful that you shared. I see a hand raised by Kanta. Kanta, would you like to come in?
Yeah, yes, Gaia. Just one comment. In the chat box, I saw some participants raising the issue about the need of giving incentive to the participant. That is very true. That is also one challenge that we are facing in the implementation process. Some of the participants are expecting remunerations or the incentive for taking interview. Otherwise, they do not give their consent for interview. This is one comment that I would just like to let everyone in this room know. There is a need of giving incentive to the participant because it takes at least 20 to 30 minutes to complete all the all the distinct questions. So most of them belong to the below poverty family. Would be because of that reason why they are expecting incentive. Thank you so much.
Thank you so much, Kanta. Yes, I saw there was a hand by Koketso, but I'm not sure if you still want to ask any question. If not,
yeah. Sorry, Kim. Just a small question. Needed some clarity because also us here in South Africa, we are involved in terms of the implementation of the CLM with some of our community-led organization. So I wanted more clarity or maybe more advice in terms of how do we go about in terms of advocacy issues that are being identified, but in terms of the needs for the community, but we get bombarded by those advocacy actions as the way we see it, there are a lot of issues. So in terms of prioritizing those issues, how do you advise in terms of us maybe prioritizing this issue more than the other issue? Because of the way we see some issues, all of them are of most important, and all of them they interchange with one another, whereby it's maybe we can say the provision of NSP is not enough, and also the need for hepatitis C training and also treatment and also education in terms of people who use drugs and not having any knowledge regarding hepatitis, but we have a higher prevalent rate in terms of those who are infected with the disease. So you can see we can't say we prioritize treatment whereby NSP is not enough, whereby people get treated and then they are going to come back and be reinfected, because also the provision of OST is not enough. We have like over 55,000 people who are homeless, and majority of them are impacted by substance use. They are using drugs, and only 3,300 rand. Only 3,300 are on treatment in terms of harm reduction services, in terms of OST. So you can see in terms of do the math, in terms of the numbers, the need is there. It doesn't even account for a quarter of the population of only those who are homeless using drugs. But when we talk also about also the others who are not street-based, maybe live at home, but still their use is been problematic to them, and they also require a OST or provision of harm reduction services. So we just wanted clarity or maybe a pointer in terms of how can we align our issues so that they can be of benefit and of beneficial to the community? Which issue can we put to the forefront? Which issue can take a backseat? Thank you.
Thank you. Thank you so much, because so I understand that the question is really about making sure that all the issues that you're grappling with are really addressed, and like the question is more about the prioritization and alignment of everything that is important to be monitored and to be addressed. I think, well, one of the answers, if I may answer, would be probably just to look at the guides that Tracy has provided us with, but also I think you know, it's really about making sure that we talk to the community and talk to the people and ask what exactly is most important for them to be addressed right here, right now. So I see that Igor raised the hand, and also, sorry, who would love to answer to? Sorry, Tracy.
That's me.
Oh, Tracy, yes. Okay, let's hear from Tracy, and then we'll pass on to Igor as well. Let's see his hand.
I think your question really directly addresses how important it is to share information with communities and gathering people and saying we have a chance to look at what's not going well with the programs we use and we have. And then to provide some more information again about like national and global guidelines and standards, and to sit around and say, well, what are the questions that we can ask to get to fixing the problem, and how can we measure it? But this always,
Yeah.
aside from technical assistance, this always has to come directly from the community. And, I've been working with different communities for more than 30 years, and I feel like even if they don't know the language that people use in the system, they know exactly what the problem is, and they're not shy about saying it. It's more like organizing that sort of problem into a question like an indicator, right? So you don't want to ask only, are you getting enough needles and syringes, as an example? You want to know how many the program is giving out. And if it's like 5, then something's really wrong. And I think it's information sharing and community empowerment. That's the basis of all of this. I hope that's a helpful answer. Thank you. It's a great question, and it's nice to hear from you.
Thank you.
Thank you. Thank you.
Thanks.
Igor?
Yes,
can
sure.
I also wanted to react to this question because it's really relevant and very good question, and it always raised this question here in our region. But the answer for me, it's really simple, and because CLM, this is about what it hurts the most. This is the most priority issue. If the community, the one issue is more painful than others, so this should be prioritized and this should be monitored for the communities. It's simple. And only then if it's really a painful topic for monitoring, the follow-up actions as advocacy will be successful. If it's like a donor-driven so-called monitoring, I cannot say it's CLM, it will never be very, how to say, good result in advocacy with this CLM. Yeah, thank you.
Thanks, Igor. Yes, Vitaly, please.
Да, и как я уже сказал коллеге, для нашего сообщества никогда не стоит вопрос, что мониторить. Никогда. Почему? Потому что я очень часто или очень много занимаюсь полевой работой. Очень много. И там, в кулуарах, там, на местах предоставления услуг, мы между собой всегда обсуждаем какие-то горячие темы, которые для нас неприемлемы, с которыми мы не согласны и которые необходимо изменить. И этот список этих вопросов, он очень большой. Вопрос, как приоритизировать, допустим, как мы это делали. Мы когда писали заявку на глобальный фонд, или, может быть, когда формировали заявку по COVID-19, мы сделали этот список, другими словами, мы собирались сообществом вместе на фокус-группу и делали большой список приоритетов. А из этих приоритетов выбирали наиболее актуальные вопросы. Были долгие споры, жаркие споры, однако, исходя из ресурсов, мы выбирали, что наиболее актуально прямо сейчас, что горит, без чего нельзя обойтись. И это должна быть хорошая коммуникация для того, чтобы это был общий продукт. Тогда, как сказал Игорь, это будет хорошая работа, никто не будет смотреть, есть у нас деньги или нет у нас денег. Мы много делали CLM при отсутствии денег, например, по туберкулезу. Когда мы были недовольны подходами каким-то, да, и предоставлением нам услуг. И мы, допустим, документировали эти случаи или собирали информацию посредством тех возможностей и ресурсов, которые у нас существуют. Это и тайный клиент, и видеодокументирование. И другой момент, что это все, вот как Игорь сказал о том, что если это будет под нашим руководством, если нам не будут спускать, что мониторить сверху, тогда это будет актуально, это будет всегда работать. Вот как-то, вот такой вот мой ответ. Спасибо.
Спасибо. Thank you, Vitaly. I see a hand from Nanao.
Hi, hello.
Hi.
It's Nanao from Manipur. So I've listened to what Kanta has talked, and that is very much happening out here. But as Tracy Swan has already said, the community empowerment is very much necessary at this point of time in Manipur also. Because the situation is, although many harm reduction programs are being placed in many of the districts across all the districts of Manipur, the program outcome is very bad. So with CLM on the horizon, and as one of the biggest objective of community system strengthening, CLM has to get rolling. And for that, the community has to be really empowered. If not, things will go hayward, as always has been in our state, and particularly talking about our context. So not as just as a saying, but it has to be very much to put on action that the community members are being empowered. This cannot happen by undermining the very essence of drug users' rights and the often right violation that is happening in our state, this forced treatment, and all those this happening almost in every part of the world where we talk about challenges towards drug user. So community empowerment is very much necessary. That is what I want to say after listening to all the presenters. And if Global Fund can do a lot of this, I think we are seeing a beautiful horizon down the line. Thank you.
Thank you so much. Okay, I see a hand from Sandeep, and I think if you have further questions, you can please put it in the chat box, but we should soon wrap up. So Sandeep, please feel free to unmute.
Hello everyone, I'm from Nepal and I'm a good activist all around the world. And I just want to, I'm from Nepal and I work in 5 different service sites of harm reduction. So I have been in the community and in the grassroots levels, and I've seen pros and cons, which have been happening a lot in our society. And like our previous members said, it should be about the community strengthening. It should be about the community. It should be coming from the community, grassroots communities. And there are lots of issues down there. And we have been there, and friends have had talked about the prioritizations of what should be prioritized. And we are in a situation because we are from the Asian country, so we have a different networks and the services, and we are always being nagging about the service quality. And it's not about the quantity, but it's about the quality, what we have been talking about since its initiations of harm reductions in Nepal. So still the scenario is the same, and the people are receiving the same kind of services. So we have to prioritize in terms of like the quality, and after monitoring, and it should be addressed from the grassroots levels, and prioritization should be from not from the AAA, but from the last Q service quality. We have to jump from that, and we have to review the guidelines and the national strategic plans, which drives all our harm reduction strategies here in Nepal. So we need to look upon it as well, and we need to actually tap on to all those things on the national strategic plan of HIV as well, for the smoother running of the harm reductions and the community led monitoring. Thank you.
Thank you so much, Sandeep. I think that I don't see any further questions and no further hands. So I think it would be probably a good time to wrap up this discussion. I think it was wonderful to hear from everyone and from so many different members from different regions about their experience and challenges. And really want to thank you on behalf of INPUD and everyone who came together to, first of all, launch this really exciting and I think very community-friendly guide, specifically designed and geared to the needs of people who use drugs. So really hope that this will become yet another but very important tool for you to make sure you collect, you monitor, and you are able to use that data to advocate for what's most important for your country, your community, and your peers, and that is to change punitive laws and policies in your country, to fight against the stigma and discrimination, to monitor the quality of services. So this is a really great tool. I hope you will make sure to have a look. I'll just share it right now with you on in the chat box, but we will of course definitely make sure to also share it with everyone via the together with all the slides. And thank you so much. And if you can turn on your cameras, so we would just take a quick picture of everyone. Thank you. Great. All right. Thanks so much. Yeah. So now, yeah, it's good. So please feel free to contact us if you have any questions. We're here for you. And thanks. Have a great rest of the day.
Thank you. Bye-bye.
Thank you, everyone.
Thank you.